From the JAMA Network, this is JAMA Internal Medicine Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Internal Medicine.
Hello and welcome. This is Dr. Eve Rittenberg, the Viewpoint and online editor at JAMA Internal Medicine. Today we're talking about a fascinating study of the unintended consequences of medical treatment. The authors examine whether starting antihypertensive treatment increases the risk of falls and fractures in people over 65 years old who are residents of nursing homes. It's a really important topic. More than 1 in 4 people over the age of 65 falls each year, and these falls can be devastating, leading to fractures and contributing to mortality. Long-term nursing home residents are especially at risk. To me, this study showcases the crucial importance of developing a patient-centered approach that balances the risks and benefits of our medical interventions, particularly for older patients with medical complexity and frailty. And so that's why we're talking about blood pressure management and fall risk today. Our guests are Dr. Chintan Dave, the first author of an original investigation titled Initiation of Antihypertensives and Risk of Fractures Among Older VA Nursing Home Residents. Dr. Dave is an assistant professor at Rutgers University and the assistant director of the Center for Pharmacoepidemiology and Treatment Science, and the academic director of the Center for Health Outcomes, Policy, and Economics, also at Rutgers. In this carefully designed study, nursing home residents who received a new antihypertensive agent had more than a twofold greater risk of fractures compared to those who didn't. This practice was also associated with greater risk of serious falls and syncope, particularly in patients with dementia. In addition, we're going to hear from an expert commentator, Dr. Canales, on the implications of this study for clinical practice. Dr. Canales is an associate professor of medicine at the University of Florida and a nephrologist at the Malcolm Randall VA Medical Center in Florida. And now to our guests, Dr. Chintan Dave and Dr. Canales. A warm welcome to both of you to the JAMA Internal Medicine podcast. So I'm going to start with you, Dr. Dave. Can you tell us why you did this study?
Yeah, thank you so much for having me. So we know that long-term residents are a highly vulnerable population that is high risk of having falls and fractures. Majority of the patients in long-term nursing home setting will experience a fall in any given year, with a quarter of these falls basically leading to serious injuries. About 10 to 15% of these falls are also going to lead to fractures, hospitalizations, and death. We know that prescription medications are a leading modifiable risk factor for falls and fractures, and antihypertensives, which can induce orthostasis and consequently, as a result, falls, are the most frequently used medication class amongst older adults. Before this study, there was really limited data on the association between antihypertensive initiation and risk of falls and fractures in older adults in the nursing home setting, as all the prior data had basically come from community-dwelling adults. So the objective of the study was to examine a cohort of long-term nursing home residents in the VA and to assess the association between antihypertensive initiation and risk of fractures and fall-related events.
Thank you. And can you tell us how you did that study?
Yeah, so we looked at the national VA data from 2006 to 2019 for the study. We identified a cohort of long-term nursing home residents who were over 65 years of age and had at least 90 days of nursing home stay to sort of exclude acute care patient population. And also they had no evidence of end-stage kidney disease. We defined the treatment group as the patients who were initiating an antihypertensive drug class, defined as an increase in the number of antihypertensives that were taken compared to the 4-week period prior. And we also required them to be on a stable antihypertensive regimen for the 4-week period prior to their antihypertensive initiation. We defined the stable use period basically as no change in the number of antihypertensive therapy. We then identified a group of control episodes such that they were also on a stable antihypertensive regimen, but they did not initiate an antihypertensive therapy, but also met the other inclusion criteria that were defined for the study population. We then adjusted for more than 50 baseline covariates, which included things like, baseline antihypertensive use, their systolic and diastolic blood pressures, cardiovascular conditions and medications, cognitive and physical functioning, and other risk factors for falls, such as prior falls and sedative hypnotic use and medications. We matched each treatment episode with 4 control episodes because we just had considerably more control episodes compared to the treatment ones. So we basically use a 1 to 4 propensity score matching, adjusting for those 50 baseline covariates. The primary outcome of interest that we examined was 30-day risk of fractures of the pelvis, hip, humerus, radius, or the ulna. And we conducted a time to event analysis using Cox proportional hazard models, examining basically the differences in the patients who initiated an antihypertensives compared to patients who did not. We also compared select secondary outcomes, but the select secondary outcomes of interest that I think would be of high relevance were also severe falls require ED or hospitalizations. And we also expanded the primary outcome to include traumatic brain injury and less common fractures that affect the rib, sternum, thoracic, and lumbar regions. We then had select sensitivity analysis that I want to highlight as well. For the primary analysis, we looked at the 30-day risk of fractures, but then we also were interested in examining the longer time horizons. So we compared risk of fractures for 30-day period, 60-day period, and a 90-day period as well. There were also select subgroups of patients that we were interested in categorizing their risk as well. And these included patients with diagnosed dementia. And we also examined sort of effect modification by thresholds of systolic and diastolic blood pressures and patients who had not used antihypertensives previously.
And can you tell us what you found in those analyses?
Yeah, so we identified 13,000 antihypertensive initiation episodes and we matched them to about 52,000 control episodes. So, for the primary outcomes of fractures relating to the pelvis, hip, humerus, radius, or the ulna, the incidence rates of the primary outcome in the antihypertensive group was 5.4 per 100 person years, compared to 2.2 per 100 person years for the control arm. This corresponded to a hazard ratio of 2.42 and an excess risk of 3.1 fractures per 100 person years of follow up.
I found that so striking that it more than doubled the risk of a fall. It was really a remarkable finding to me. So that sort of stood out from the study as I was reading it.
Yeah, we were also really surprised at the high risk that we found. And the thing that stood out to us as well was not only the high risk, but the fact that it was consistent across several sensitivity analyses, several subgroups, and even things that we looked at, for example, severe falls, which required an ED visit or hospitalization, that greater than twofold risk was still manifest in that sort of an outcome that is slightly different phenotype than fractures. But so that risk was consistently high. And also, when we looked at the expanded outcome that also included TBIs and other fractures, we also saw that greater than twofold increase in the first 30 days. So we were interested to also examine whether this risk attenuated over time. So when we looked at, what happened when we changed the maximum 30-day follow-up to 60 and 90 days, we saw that the hazard ratios did attenuate with an increased follow-up. So they went from about 2.42 for the primary outcome of fractures at 30 days to 1.87 at 60 days and 1.72 at 90 days. So we also wanted to highlight that the fracture risks were higher for certain subgroups of patients numerically, but did not reach statistically significant difference from the primary cohort. So in patients with dementia, the risk of 30-day fracture was 3.2 times higher. In patients with a systolic blood pressure of greater than 140, it was 3 times higher. And diastolic blood pressure greater than 80, it was 4 times higher risk. And the highest risk, numerically, at least what we found in patients, was patients who did not have an antihypertensive in the 4-week period prior, and that was 4.7 times higher risk of fractures.
Great, thank you so much. I'm going to turn now to Dr. Canales. Mana, I wonder if you could speak to us about the design of the study and what made it so powerful and able to come up with believable findings.
Right. Well, I think it's a really important question, Eve, and it's the first thing I do before I even begin to think about the implications of the result of a study is I look at the study and try to decide, is this a valid study? Does the study have strong internal validity, meaning I can be confident that the results of the study are valid? And so, in an ideal world, Dr. Dave would do a randomized controlled trial of starting nursing home residents on new blood pressure medications and then following them for a long period of time. But it takes a lot of time and it takes a lot of money. And so instead, Dr. Dave capitalized on the wealth of clinical data we have in the VA and used what's called a target trial emulation design, where he took retrospective data and assigned treatment groups within that retrospective data as if this were a trial in an effort to minimize selection bias. Furthermore, when assigning veterans to the treatment arm, he required a 4-week washout period, as he said, for entry to that arm, much like we would do in a trial of treatments. And then to balance the comparison groups on factors that might predict antihypertensive use that are also important for the outcome studied, he propensity score matched on over 50 key variables that he balanced between these groups, which is extremely powerful. And then finally, he used an intention to treat analysis as well as a per protocol analysis for transparency. So all of these measures, coupled with a large sample size, which allowed for adequate power for all of the important subgroup analyses that we want to know about, really increased the confidence that we can count on the results of this study as valid.
That's so interesting to me to think about how to make an observational study as close as you can get to the power of an RCT. So, really interesting to think about. I wonder if I could now ask you for what you do think are the takeaways from this study for practicing internists. Why do you think that these findings are important to our practice?
Ultimately, you want to think about how to interpret the findings of a study into your practice. And for this study, we really want to think about how we interpret the findings in the context of what we know about the benefits of antihypertensive therapy. Eve, I think you probably would agree that most internists say, yeah, treating hypertension is a good idea, right?
Mhm.
It's hard to ignore trial data that show benefit from blood pressure control. For example, in the SPRINT trial, tight blood pressure control was associated with improved cardiovascular, kidney, and cognitive outcomes, even in older adults. But also, just like we talked about internal validity, it's important to think about external validity. And I would argue that none of the nursing home residents in Dr. Dave's study would have qualified for any of these trials. As such, the applicability of this trial data to nursing home residents is really unclear. And I think when we consider just how devastating the impact of falls and fractures are on older nursing home residents, I would say the take home message from this study is that we should be careful and thoughtful when we treat blood pressure in the nursing home. So, what do I mean by careful and thoughtful? Careful means in an ideal world, around initiating new blood pressure medications or even changes in blood pressure medications, maybe we would check vital signs more frequently, maybe every shift instead of once a day in the nursing home. We might even check orthostatic vitals for the couple of days after we initiate a new blood pressure medication. And when initiating or changing blood pressure medications, I would say start low and go slow. So you're starting a new medication, start with the lowest dose possible. And then don't rush to make changes. It takes at least 2 weeks really to see the full impact of a new medication or a medication change. And even in big trials like SPRINT, no changes were made sooner than 4 weeks after initiation of a drug or change in a dose. So start low and go slow. And then I think we need to be thoughtful. So, thoughtful means we need to consider the patient's circumstances and preferences. It's not a one size fits all approach. Nursing home residents are a diverse population and they have varying degrees of multimorbidity and disability. So, for example, you have two nursing home residents that are 80 years of age. They have different life expectancies. We wouldn't apply a therapy with benefits on the order of 3 to 5 years to a patient who just has 1 year of life expectancy, right? Also, I would say that some older patients just don't feel good at lower blood pressure. And so we as healthcare providers should feel comfortable registering this and modifying our plan to meet our patient goals.
Thank you so much. It's so much to think about. And Dr. Dave, I'll ask you if you have one last takeaway or clinical pearl for people from your study as well.
So yeah, I think I'll just reiterate the points about starting low and going slow with antihypertensives in general, treating the patient and not the number, and also just keeping the risk of fracture in mind when initiating these therapies in nursing home populations, especially among patients who have dementia or higher blood pressure values, and residents who've especially not used an antihypertensive recently.
Well, thank you so much. This has really been terrific. Clearly, we could talk about this topic for much longer. Thank you so much for being here, for your excellent work. This is Dr. Eve Rittenberg, the Viewpoint and online editor at JAMA Internal Medicine. I hope you've enjoyed this JAMA Internal Medicine podcast. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.